She's visiting us from Bend, Oregon. Dr. DeMeester finished her residency here in 2006, during her senior year, she was chief resident. After she finished residency, she joined the faculty at Mercy and was there for a year before moving back home to Michigan, where she was on faculty at a community hospital, which was an affiliate of University of Michigan, as I recall. She was there for 14 years, and while she was there, she was director of the observation unit and was a cardiology liaison. She did some great research, including a very nice study that was done on the heart score and shared decision-making that got a lot of publicity at a national level. And in recent, a year ago, 2 years ago? A couple years ago.
Yeah, almost 3 years ago.
Almost 3 years ago, moved out to Bend, Oregon, where she still practices community medicine. Despite being in the community, she still stays very involved in academics. She's done podcasts for MRAP, and she lectures nationally. She's lectured at AEM and ACEP. She's lectured here at the Crashing Patient Conference, and she has a particular interest in women and heart disease, and also syncope. And she's going to be spending some time with us today talking about landscapes of syncope. So, Suzy, welcome back.
Well, thank you for that introduction, and thanks for having me. This is a bit of a homecoming for me, so I'm going to use the time not only to talk about syncope, but also let you know what I've been doing for the past few years. But before that, let's travel back to 2004, which I realized was 20 years ago. And I was a second-year resident. And at the time when you were a second year, and I don't know if it's changed, but you had to do an evidence-based research presentation. And I chose the use of sodium bicarbonate in the ED, which I was kind of excited about. And I'm giving the talk, and it was in a much smaller room. And in the very back are Amal, Mattu, and Ken Butler, and they're yawning. They were like repeatedly yawning, nodding off, and if we would have had iPhones at that time, I know they would have been surfing or checking Twitter. And at that moment, I vowed never to give a boring lecture again. And so that's my goal. So I'm going to ask you to do something that you don't usually do in an emergency medicine lecture. That's turn on that artistic side of your brain, relax a little bit. We're going to explore landscapes of syncope. My objectives are pretty simple. Keep you entertained and hopefully awake. And maybe a refresher of some basics of syncope, but also impart you with some new bits of knowledge when you see your next patient in the emergency department. I don't have anything to disclose. I would say maybe the photography is a combination of mine, my husband Jim, some of you know him, and then some local friends in Bend. And so I moved to Bend about 3 years ago. It was definitely a pandemic, pretty unplanned decision. I now practice in Central Oregon, so it's the only trauma center that's on the east side of the Cascades. We have a very large encatchment area, high acuity, about 200 to 300 miles. We're the only hospital. You have to transfer over the mountains, which sometimes isn't possible due to the weather. And I work for a democratic group of 25 emergency physicians. So pretty different from where I was for the 15 years that preceded that, and definitely different than University of Maryland. So before we get into the fun stuff, let's define it. Syncope is the transient loss of consciousness characterized by a relatively rapid onset, short duration, and spontaneous recovery, and is due to global cerebral hypoperfusion. So some key phrases here. What's not syncope? This is probably more important. This is Blaze, my Aussie doodle, who's always sleeping. Hypoglycemia, this is a big one, right? EMS is always excited to tell you what the blood sugar was. And by all means, we should be checking blood sugars on patients who come in altered or lost consciousness. But remember, according to that definition, we need spontaneous recovery, right? And so a patient who's hypoglycemic, they don't have spontaneous recovery. Passed out on the couch, you drank too much. That's not a syncope workup. Dizzy. We see these patients every shift, right? We hate these patients. I just had one like 3 days ago. I really make my patients commit, and they often don't want to. Would you like option 1? Option 1 is lightheadedness, pre-syncope, I passed out. Or, not and, or you can have option 2, which is ataxic, vertigo, motion sick, because that's a CNS workup. That's not a syncope workup, right? And then lastly, seizure. So this is a big one. I think, bystanders will often describe this myoclonic jerking that we can see with this global cerebral hypoperfusion and syncope. And so for me, it's a good rule of thumb to get an EKG on all my seizure patients. And then similarly, we want to ask bystanders, did the patient bite their tongue? Was there loss of bladder or bowel control? Were they confused for a significant period afterwards? So what's the big deal? Why do we care, right? These patients, they often look really good in front of us. They've returned to baseline. In fact, how often do you have the patient asking if they can leave the emergency department when you walk in the room? The big deal is, and I think I learned this here from you, is that syncope is on this continuum. And at one end, we have lightheadedness or pre-syncope. And then we have syncope, right? The patients actually had the syncopal episode. But on the other end, we have what? We have asystole. We have sudden cardiac death. And so it's our responsibility to identify those life and organ threats and prevent a future case of sudden cardiac death. And this is perhaps the most important slide of all of emergency medicine. I know, bold statement. But this is how we should approach every single patient we see. We think about life and organ threats first, right? PE, dissection, ectopic, AAA. Then, what's most common? Well, for syncope, that's going to be orthostatic syncope, vasovagal syncope. And then we look at that patient in front of us. We've taken a history, done our physical, and we've looked at that EKG. And we ask ourselves, what's the most likely cause for my patient? And when we've ruled out some of those other life threats, what we're really asking is, did something cardiac cause my patient to lose consciousness? Is it something structural? Thank you, Dr. Farzad, for sharing your echo with me of this tamponade. Or something electrical, a dysrhythmia. Or maybe it's a combination of both. Which brings me to the one test we need, right? The ECG. This is the single most important test you need when you're evaluating a patient, and it's often the only test you need. So I was preparing for this talk, and now I've been in Oregon for a couple years, but I am still floored and enamored with its beauty. And I was also trying to make, again, this talk not something that people would yawn or fall asleep over. And one of the nice things with our move was that I picked up some new hobbies and new skills, which is always pretty exciting when you're in your 40s to find something new you can enjoy. And so we've been mountain biking. So I was out mountain biking one day and thinking about syncope, and I was gazing off into the distance gazing off into the distance and started to see in the mountains and in the trees. And I remember, I think I texted some of you here that I started to see rhythm strips in the landscapes. And for the rest of that summer in particular, but even since, I do tend to annoy my family by pointing out that, there's ventricular tachycardia over there, there's asystole over there. But what I realized was that nature and the ECG have more than just the appearance in common, and that's the perspective. So we put on leads, right? We put ECG leads on a patient so we can get that 360 view of the electrical activity. And that's what we do when we're taking hikes, exploring nature, using photography to capture emotions. So I'm going to ask for some creative leniency here, right? But I'm also going to have you just come explore the Oregon ECG landscapes of syncope with me. So ischemia, this is the elephant in the room. You are not going to miss ischemia, right? Patient comes in with ST segment elevation, like we see here in the Columbia River Gorge. You're going to catch that on the ECG. The patient is going to have a worrisome history. They are going to look often like crap when you see them. And again, you're going to be looking at the EKG. So pictured here, Columbia River Gorge. It's a couple hours north of where I live. It's one of the reasons we moved, because in the Columbia River Gorge, not only is it absolutely beautiful, but it's also always windy. And while that makes for a really bad hair day, my family is very into wind sports. And so it's a home of kiteboarding, windsurfing, and they in particular are learning, or I guess practicing kiteboarding at this time. So ischemia, again, you're not going to miss the inferior myocardial infarction. You're going to catch the patient with ischemia. Similarly, the obvious dysrhythmia that you see, the patient who's in third-degree block, you're going to catch that. The patient who is suffering VTAC or VFib, like pictured here at the Mount Bachelor Nordic Center, you're going to catch those patients. What's probably more important to realize are the dysrhythmias you should not blame for the syncopal episode. AFib. AFib gets a bad rap. AFib is super common. I love talking about AFib. But AFib is usually really well tolerated. Patients are unlikely to lose consciousness simply because they are in AFib with RVR. Now, PE, sepsis, those things can cause AFib and certainly can cause a syncopal episode. But AFib, as well as SVT, MAT, sinus tachycardia, do not blame these dysrhythmias on the loss of consciousness. So the rest of the time we're going to spend is with what I like to call the fatal five. These are the 5 ECG diagnoses you should not be missing and you should be looking for on every EKG. These are Wolff-Parkinson-White, prolonged QT, Brugada, hypertrophic obstructive cardiomyopathy, and arrhythmogenic right ventricular cardiomyopathy. And what I do, I actually dictate this into my MDM. ECG without those gimmies, the ischemia, dysrhythmia, and then WPW, prolonged QT, Brugada, HOCM, and ARVC. And I actually dictate this. I do not use a macro because I never read my macros. So here we are at Three Creek Lake. And Three Creek Lake is about a 40-minute drive because the roads are horrible away from where I live. But it's also the base of the Tam MacArthur Rim trailhead. And it's an out and back hike up to Broken Top. So that's the mountain pictured in the back, and which is essentially a blown off volcano, which has a lake at the bottom, but as well. But out and back hike, moderately strenuous. We took 2 teenagers with us, so lots of complaining. But the goal is to get to, let's see if I can get the fancy pointer to work. This is the Tam MacArthur Rim, this little lip here to the left of Broken Top, because from there you have a beautiful panoramic view of the Cascade Mountains, Mount Bachelor. And when you come back, you can jump into this lake, but if you're prone to hypothermia like me, you can watch the rest of your family do it. And I gazed off into the distance, and what do you think I saw? I saw a delta wave. And we see, I asked for creative leniency here, but we see delta waves with what? Wolff-Parkinson-White. So this is a congenital pre-excitation syndrome, right? It's characterized by an accessory pathway. And it was first described by Drs. Wolff, Parkinson, and White in 1930. And they published a case series in the American Heart Journal describing patients with this condition. What do we see on the ECG? Because of that accessory pathway, we see that delta wave, right? Short PR, and as a result, we have a wide QRS. So again, what we're looking for, as in Broken Top, we're looking for that delta wave, short PR, and wide QRS. And how do patients get into trouble? Patients get into trouble when things get too fast, when that accessory pathway is favored. So here we have a wide irregular tachycardia. And you've all been to Amal School of EKGs, right? So we have only 3 things in our differential for a wide irregular tachycardia. And what are those? Polymorphic ventricular tachycardia. This does not look like torsade. AFib with a bundle, and AFib with WPW. So how do we differentiate from those latter 2? Well, we take a look at those QRS complexes. And when the QRS complexes are not identical, so they differ, there's varying morphologies, we should be concerned about AFib with WPW. Another example. we know this is not polymorphic ventricular tachycardia. We look at the QRS complexes. They differ. They're not identical. We should be worried about AFib with WPW. And why does that matter? It matters because when we come to treatment, we need to unfortunately avoid numerous classes of medications. And these are those that block the AV nodes. So no beta blockers, no calcium channel blockers, no amiodarone. We're left with my favorite electricity. It's fast, it's clean, safe. Or if your department stocks procainamide and you're comfortable using that, that's option 2. Bless you. So even though I've been out in Oregon a couple years, it wasn't till this September that we visited Crater Lake. And Crater Lake is a national park. It's also the deepest lake in North America. It's nearly 2,000 feet deep. And it is very pristine because you can see there's this rim around the lake, and there's really no beaches. So you're not seeing boats, there's no motorized boats. And 2 days a year, they close this rim around Crater Lake to motorized traffic. And they have an event called Ride the Rim. And you can bike around the 36 or so miles around the rim. And so I underestimated 2 things when I did this with my husband in September. And luckily, the kids had some other activities, because I know there would have been a lot of torture if they had to do this ride. But one, Crater Lake is absolutely beautiful, and I couldn't believe it took me 2 years to get there. And 2, it was a very strenuous ride. In fact, about 8 miles before we were done, we thought we were done. We were at some welcome center, and they told us, no, you still have 8 miles, and it's all uphill to go. But I had a lot of time to stare off into the distance. And from this particular vantage point of the rim, what I was seeing was this really prolonged period between the 2 peaks, or the small peaks that I could see along the rim. And that leads me to prolonged QT. So prolonged QT, this is an autosomal dominant condition, right? It's a channelopathy, and probably a good time to pause and say that all of these fatal 5 have some sort of genetic predisposition. So this is where actually asking about family history is important. We're measuring from the Q to the end of the T interval. And what's interesting is that even though we talk about this so much, I feel like every shift you're probably looking at a QTC, there's no universal definition. And it can differ a little bit from ECG machine to ECG machine. So for men, usually it's about 450. Women, it's 460. And I want everyone to remember the number 500. And that's where you start looking at medications and checking electrolytes. So again, we're measuring from the Q to the end of the T interval. Patients get into trouble here when things get fast, when we have this R on T phenomenon, which can precipitate torsade. Okay, so causes. Genetic predisposition. Unfortunately, about 13% of patients, their first episode is sudden cardiac death. And it's usually with a 2-hit phenomenon. So they have undiagnosed congenital prolonged QT, and then they're inadvertently given one of the hundreds of medications that can prolong the QT. Or maybe they have an electrolyte abnormality. Hypo-K, hypo-MAG, all of these can predispose to prolonged QT. And again, patients get into trouble when they have this polymorphic ventricular tachycardia, which in the case of the prolonged QT, we term torsade. So 500, that's the magic number. That's where you start looking at the antiemetics, antipsychotics, taking a look at the patient's medications, and asking maybe about family history if you have not before. Now, what do you guys do when you have a prolonged QT, or QTC, right? That's the C means correction for heart rate variability. What do you do in the setting of a wide QRS? When the patient has a baseline, let's say you're a right bundle branch block like we see here. Well, the machine is reading it as 525, so prolonged. We should be worried, but kind of intuitively you're thinking, well, a lot of that is this wide QRS that the patient's always had. Are they really at risk for torsade? No, in fact, they're not. So what can we do? We can calculate a modified QTC interval in the setting of a wide QRS complex 2 ways. You can do a simplified method. So just take the QTC and subtract half of the QRS duration. So that's an easy way to do it. It does tend to overestimate the patient's risk for Torsade. Probably more accurate is the JTC interval. Are you guys using a JTC interval? No? So we know what the J point is, right? That's our takeoff for the ST segment. We measure from the J point to the end of the T interval, and that's called our JTC interval. And that's been shown to be more sensitive, more specific when we're actually talking about risk of Torsade. The important thing here is that the cutoff is different. So you need to remember 420. If you can't remember that, then just go back to the simplified method. Let's do an example with the previous ECG. So simplified method. Our QTC is 525, right? And we're just gonna kind of eyeball it half of the QRS, which is 136. That gives us 457 as our modified QTC interval. That's not over 500, but still, it's kind of on the borderline. Let's look at the JTC interval. So we're measuring from the J to the end of the T, and so that's 525, and we just subtract the whole QRS, and that's 389. And remember that magic number was 420. So if you can remember 420, I would recommend using the JTC interval to estimate your patient's risk of Torsade. This is Smith Rock, and Smith Rock is one of those bucket list items that might even come up on your Instagram feed now that we're talking about it. And it's one of the places we always take our visitors. It's close to the airport. It's a mecca for rock climbers, but also really great hiking. And along the back side of this rock formation is my favorite hike. It's called Misery Ridge, and it's called that way for a reason. But it's a really steep uphill. You can do it in 30 minutes, maybe 45 minutes, kind of depending on your fitness level. But you're rewarded with a beautiful view when you get to the top. And I think you could pretty much make out any dysrhythmia in Smith Rock. But this day, I saw an incomplete right bundle branch block with ST segment elevation. And when we see this, what do we think about? We think about Brugada syndrome. So this is another autosomal dominant condition, channelopathy, thought to be responsible for 20% of sudden cardiac death in young patients. There's some different morphologies, but generally what we're looking for, as we saw in Smith Rock, is a incomplete right bundle branch block with ST segment elevation in lead V1 and V2. This is Pedro Brugada. He was initially destined to be a Spanish farmer, but became one of the foremost electrophysiologists in Europe. And he, along with his two brothers, became obsessed with a family whose children were suffering cardiac arrest. And what he noticed was this ECG pattern, and it took him several years, many years, this was in the 80s, to get recognized, but he was eventually recognized as the expert in this syndrome, which was for a long time just written up as incomplete right bundle branch block associated with ST segment elevation leading to sudden cardiac death. And at one of his talks, someone stood up and said, "Can we just call this Brugada syndrome?" And that's how it got its name. So we're looking for incomplete right bundle branch block, ST segment elevation. These patients are prone to electrical instability, ventricular tachycardia, VFib, and cardiac arrest. And the current treatment is an AICD. Pearls about Brugada. Brugada is sneaky. It's not always there. It's often unmasked by stressors, and fever is a big one. So patient comes in tachycardic, febrile, they have pylo. You see this pattern, you resuscitate them, and the pattern goes away. Well, what do? Well, this is somewhat institution dependent, but usually what I do is I would call cardiology. And again, institution dependent, but they will usually ask us when we're calling with a syncope patient, or in this case, Brugada, to order the cardiac monitor, the outpatient monitor, to kind of jumpstart things. It is critical that if you're concerned about Brugada, that you're ordering that as the indication. So not just syncope, you need to specify Brugada. Because what that monitor needs to be reviewed for is not just a dysrhythmia, but they should also be looking for evidence or appearance or disappearance of this Brugada pattern. So one of the downsides of Central Oregon is smoke in the summer. And I think, did you guys get smoke last summer? And we weren't really prepared for that, but what we've learned is I pick up more shifts in August, so I don't feel bad that I'm missing anything. And then we also escape to the Oregon coast if we can. And if you've never been to the Oregon coast, I highly recommend it. It's a cold coast, so there's not really sunbathing. There's really not very many people. You can walk for miles. And this was a first for us. This is in Bandon, the Bandon Dunes. And those of you who golf may know that Bandon is very famous for golf. We don't golf, so we went hiking and mountain biking. And then someone told us to catch the tide pools at low tide because you can see starfish and jellyfish and all kinds of ocean life. And the other thing that you can see are these rock formations, which are typically covered with water, and they're unmasked at low tide. And so I was out there walking. Of course, I was thinking about, ECGs and dysrhythmias. And my attention was drawn to this very jagged rock formation on the left that looked like a dagger to me. And when I think about syncope and dagger-like, I think of the dagger-like Q waves of hypertrophic cardiomyopathy. So this is the leading cause of sudden cardiac death in young patients. We always talk about asking about family history, and that's important, but especially with hypertrophic obstructive cardiomyopathy, about 50% of the patients do not have a family history. These patients have hypertrophy of the septum. They're prone to outflow tract obstruction, so that can cause syncope and dyspnea, and also electrical abnormalities. So board question, 17-year-old basketball player, they collapse on the court, right? They're resuscitated. They're later found on echo to have HOCM. Real life. Patient comes to your ED. They're in their late 20s, they're in their 30s, because they're not an elite athlete, and they've been able to compensate. They've done pretty well for their first couple decades. Dyspnea is the most common presentation. So I think when you're seeing some of these ECG signs that we'll talk about, the clinical picture doesn't quite fit the patient in front of you, this would be an opportune time to refer a patient for at least an outpatient echo. Clues, dagger-like Q waves. If you look at leads 3 and AVF here, you see these deep, narrow, dagger-like Q waves. And these are different from those of myocardial infarction because they're narrow, so less than 35 milliseconds. You also will see, depending on how long the patient, or how advanced the patient's condition is, you will see QRS complexes, LVH morphology, and it doesn't quite fit, right? You're seeing a 20-year-old, they're not hypertensive, you're seeing this ECG, this patient needs further workup for HOCM. And we have arrived at our last destination, and this is a bit of a secret spot, so if you come visit, I will take you here. But it is near the Newberry National Volcanic Monument, near Paulina Lake, and it's a series of natural water slides. The rocks are actually the water slides, and it's punctuated with these tide pools and waterfalls. And so we hiked up to this one. This one was like 2 miles away, so not super far. And we had seen some people jumping off that waterfall and read that you could jump off the waterfall, but the rest of the tide pool is only like knee height. And so being a good ER MD mom, I decided to go first just to make sure it was safe, and I survived, here to tell. And so then I watched my kids jump off the waterfall afterwards, and I sat here and my eye was drawn to this little blip after the waterfall because I thought it looked like an epsilon wave. So, and this is Lucy, pictured here. She looks a lot more graceful than I did. So, autosomal dominant condition. This is arrhythmogenic right ventricular cardiomyopathy. It was previously known as dysplasia, now kind of favoring cardiomyopathy. And this is the second most common cause of sudden cardiac death in young patients after HOCM. So, as the name implies, affects the right ventricle, and what you have is fibrofatty infiltration of the RV. But we now know that it really affects the left ventricle in many of the cases as well. And unfortunately, these patients are prone to electrical instability, sudden cardiac death. Any family history, this patient needs a cardiac MRI. So if their parent, uncle, that sort of thing, has had a diagnosis of arrhythmogenic right ventricular cardiomyopathy, you need to take that really seriously. They definitely need further workup for this. If you're lucky, you will see an epsilon wave. So an epsilon wave is a little blip like that rock formation after the QRS complex. Unfortunately, it is found in only about 30% of patients. And you'll often see it in combination with T wave inversions in the anterior leads, V1, 2, and 3. So how can we diagnose this? Well, on standard EKG, you can look for that epsilon wave. However, that's only present about 30% of the time. You can ask for something called a Fontaine lead. Do I do this on all of my patients? Definitely not. If there's a family history, if it's a young patient with a concerning story for syncope, I would probably recommend doing this. So I would recommend that you just Google the placement right before you do it, because you won't remember it. It's really moving leads 1, 2, and 3 over the RV. And the hope is to capture an epsilon wave. And the sensitivity goes from 30% to nearly 50 to upwards of 75% with a Fontaine lead. So same patient, standard EKG did not show an epsilon wave. We use the Fontaine lead, and we can see the epsilon wave. And once you're suspicious, the next step is to do a myocardial biopsy. No, we don't do those very much. Do you guys do those here? No. The next step is to refer the patient for a cardiac MRI. So this is really the gold standard for diagnosing arrhythmogenic right ventricular cardiomyopathy. So some takeaways here. We're going to think about life threats first, right? We use that for all of emergency medicine. We need to take a good history, and we need that ECG. The other tests depend on the presentation. We're going to think about ischemia and dysrhythmia, and we're not going to miss those. And then we're going to inspect every ECG for those fatal 5, right? WPW, prolonged QT, Brugada, HOCM, and ARVC. And the last takeaway is really just a personal note really for the residents, and that's just don't wait. And that doesn't mean you need to quit your job and move across the country. But what it does mean is you guys have extremely hard, we all have really hard jobs, and we've learned that during the pandemic, even more so. And so find things that bring you joy and incorporate them into your daily lives. And it does, again, not need to be super dramatic. It can be walking your dog, turning off your cell phone to spend time with your family, becoming a coffee connoisseur, wine tasting, Peloton yoga, EKG guru, whatever it is. Just don't wait for vacation and try to do it every day. And that's it.
That was really great. And just for all of you to know, I did not ask our speakers to talk about EKGs, all right? Dr. Miller, got a few minutes for questions for Dr. DeMeester.
Thank you, Dr. DeMeester. We have a couple questions from the chat. The first is, could you please clarify EKG differentiation between AFib with WPW and AFib with bundle branch blocks?
Okay, I think I could maybe go back to one of my slides. Let me do that. And since I have the luxury of having Dr. Mattu next to me, he can feel free to add more. But what I'm typically doing, so wide irregular tachycardia, and we've already decided this is not polymorphic ventricular tachycardia. What I'm doing is I'm looking at the QRS complexes. Oh, let's see if that. Well, I don't know. Well, is it different? So I'm looking at the QRS complexes, and we can see that, for example, the ones in 3 look very different from the ones in V3, V6. And so when the QRS complexes, okay. When the QRS complex morphologies appear different, I'm worried about WPW. I didn't mention during my talk, but if you have access to an old EKG, that would be very invaluable to see if you see any signs of WPW, so delta wave, or looking back at history. So I don't know if that answers the question, but I can also defer to Dr. Mattu.
Sure, I agree. I think that the main thing with AFib bundle branch block is that all the QRS complexes will pretty much look alike, whereas AFib WPW, you see the QRS complexes are really changing quite a bit. The same thing that Suzy said in a different voice. Questions?
All right, a few more just came in, so bear with me while I sort of read through them. Are you able to discuss the differentiation between epsilon wave and the morphology of benign early repole? Are there any sort of overlaps there that you would find easy to differentiate or concerning to differentiate?
I think with the epsilon wave, you're not necessarily looking for any ST segment elevation. You're really looking for a small blip almost after the QRS segment, almost like that rock. That's isoelectric. And I will say that when if you're looking at examples of epsilon waves, the ones I showed were pretty obvious, but honestly, a lot of them almost look like an artifact. It's such a small little deflection, and that might prompt me, to get those Fontaine leads. I would say that an epsilon wave would typically, I think, in most cases, be missed if someone handed you a triage EKG. So it would really be in conjunction with that history or family history where you'd go back and look for it.
Excellent, thank you. And the last one that we have is if you have a story concerning for HOCM and an EKG and a bedside echo that's also concerning for HOCM, is that sort of the end of your ED evaluation? Do you initiate medical treatment from the ED, or do you routinely admit those patients or consult cardiology? Like, what's the next step there?
I think that's pretty institution dependent. I practice in a community setting right now. Our cardiologists typically don't come to the emergency department and are not always in-house. So I would be calling cardiology. These patients are typically managed with medical therapy, especially early on, so like rate controlling agents, beta blockers, and then some of them are getting ICDs eventually. So I think I would not necessarily be admitting this patient. I think I would probably defer to the cardiologist. They may have me start the patient on a beta blocker. And if I can guarantee close outpatient follow-up, I think that would be reasonable. Now, certainly if they had a syncopal episode and I was worried about a dysrhythmia causing that, I might be more prone to admitting them versus just exertional dyspnea or something like that.
Popular questions about the epsilon wave here again. So there are two people just asked how to differentiate between an Osborne wave and an epsilon wave.
Thermometer.
Besides the thermometer, I guess. I don't want to say that, I don't want to get in trouble, but here we are. Okay, all right, great.
That, just use a thermometer. So I think we're right at our break time, but I got a few things. Most of the questions I got on my cell phone had to do with possibility for visiting rotations in Ben, and also you'll be happy to know Dr. Butler is watching online.
Oh, good.
And wanted you to know that he did not yawn a single time during the talk. So.